All right, so my name is Emma. I'm a fourth year medical student. Today, we're going to talk a little bit about seizures, a little bit about epilepsy. This is, predominantly a neurology topic. So it looks like the last 2 weeks have been kind of emphasizing neurologic concepts. So hopefully you guys are learning something. Hopefully you guys can learn something from tonight's presentation as well. If this is your first time, welcome. We'll kind of go through the setup and everything here in a couple slides and really what your role is tonight. If it's your multiple time being here, thanks again for joining us. We certainly appreciate that. This is always a high point of my week for sure. All right, so let me share the pre-poll here, and don't worry, I actually changed it this time. It doesn't say like HIV or whatever topic we were talking about last time, but take a couple seconds here to answer your level in terms of knowledge of seizures and epilepsy. All right, so I'll share the results here. It looks like some of you guys know a little. So it seems like this is a topic where, probably because of its, prevalence in terms of, awareness in that regard, people may know a little bit more about it. So that's great. We're going to talk kind of a surface level introduction to seizures because it can be a pretty kind of in-depth and complicated topic. So, we'll certainly keep it at your level. And if I'm ever not on your level or you have a question about anything, feel free to put it in the chat or unmute yourself or however you feel most comfortable. But really what we'll do here is kind of introduce you to a few topics, a case, and kind of go through those things to kind of cement certain ideas into your head for tonight. All right. Okay, so here's kind of the session outline as I was kind of alluding to, but basically what we'll do is we'll go through a case, we'll talk about the physical exam, we'll talk about case details, we'll kind of go through and brainstorm a differential diagnosis, much as we had last week when we had our patient actor, which I'm still laughing at. She's very funny. I don't know if you guys were there, and I think a few of you guys were, but I'm still laughing at when she said pocketbook. So now every time I see my phone or my wallet, I think pocketbook because of Bridget. But other than that, we are going to go through the assessment and plan. So we'll talk about the differentials, and then we'll talk about what we do in order to treat those different differentials or what we think is going on with the patient. Okay, and finally, we'll kind of wrap it up with a lesson on the pathology so that you guys can learn a little bit about it. This presentation, like a few in the past, I've kind of thrown in a couple slides to give you a little bit of background knowledge amidst the case so that you're not completely in the dark, especially for certain concepts that are pretty in depth. Okay, because of the holidays, the quiz will be due on the 11th. The quiz is fairly easy though, guys. I hope you guys don't have any problems with my quizzes. I make them pretty pretty surface level, pretty simple, so that hopefully you can watch the actual presentation, type up the stuff in your SOAP note, and then kind of be done with it after that. If you ever run into a problem and you think my quizzes are too hard, let me know. I'd be happy to lighten up on you guys. That's certainly not my intention by any means. I try to keep it simple so that you guys are recalling the biggest topics of the presentation. All right, let's keep going here. Here's the SOAP note form. So for those of you that are new, let me put that in the chat again. Here's the link. It has the SOAP note, it has the quiz, it has everything that you'll need. So you can kind of visit that. But basically what the SOAP note is a acronym for how we kind of write our notes here. So that's SOA, and then P is over here. So the subjective part is basically the things that we find. So things like the HPI. So when the patient comes in and tells us why they're there, that's the history of present illness. That's what the HPI is. And then ROS are things that are pertinent positives and negatives. So things that have to do with the chief complaint. If someone comes in with a headache, for instance, and we ask, do you have photophobia, meaning the light hurts your eyes, or phonophobia, the sound hurts their headache, or if they have nausea or vomiting. Those are pertinent positives and negatives that we want to know that might kind of tip us in the direction of one etiology over another. All right. And then the other thing is objective. So things like the vital signs, the physical exam, are things that we're including in the objective portion of our note. And then the assessment, if somebody comes in with a headache, for instance, we're listing what we think is going on based on our testing, our exam, everything like that. So if we think it's a brain tumor, number one, we're going to say brain tumor. And then the plan is going to be what we're going to do for that diagnosis. All right. So a lot of the information will be made pretty clear throughout. If you guys have any questions about the SOAP note or anything, feel free to kind of to ask it along the way. I'm certainly happy to answer any questions you have. Like I've said before, I don't feel like your questions are dumb questions. I was always that person that was never asking questions because I thought everybody would think I was dumb, but I guarantee 50 other people have the same question. If there were in fact 50 people in this room tonight, but I guarantee someone else has the same question as you. So don't feel ashamed. All right, like always, go ahead and pull out your annotate button, pick the stamp or whatever you want to do and kind of stamp where you're at tonight. Well, it's California. Okay, there's some East Coasters too. 1 Central Time. The other Floridian is here. Good to see you. All right, perfect. I think I gave everybody an ample chance, hopefully, to mark where you're at. Thanks for coming wherever you guys are at. I will say, not next week, but the week after, we'll be doing medical ethics. I was very excited. I've already made that that presentation, so that should be a really good one. There's a break in between now and then. I think the presentation's on the 12th of January. So there's one in between this one, obviously, and the medical ethics, but I think that's going to be a good one. It's going to be a pretty unique one. We're going to go through some cases in medical ethics. So it'll be good kind of exposure, I think, for you guys to talk about things that are going on. Bioethics and chem ethics lectures. Yeah, that's awesome. So some of the things that I'm talking about may kind of come up or have come up in some of your guys' courses when you talk about ethics. So perfect. And like always, if you guys have any topics that you want to hear about, definitely let me know. And if it's out of my wheelhouse, hopefully I'll find somebody to talk about it. Maybe we can have Bridget back to talk about pediatrics or something. That's she likes peds a lot, which it's not my favorite sport. So less likely that I'll talk about peds here. All right, let me clear. Oh, I'm stamping all over the place. All right, so here's our case. Basically, so let's read this out. So we have a AP, a 17-year-old male who's presenting for a suspected seizure. The patient was preparing to take his final exam in algebra when the seizure occurred. Witnesses report that the patient slid off of his chair and began to exhibit generalized shaking while he was seemingly unconscious. No head trauma or urinary incontinence occurred during the event. The patient continues to exhibit seizure-like activity upon arrival with EMS. The patient's mother is present, of whom denies any recent illness or concurrent illness, though states that the patient complained of the smell of popcorn before the seizure. In terms of past medical history, that's what PMH means. Multiple concussions due to contact sports, no medications, no alcohol or tobacco use, no allergies, and no family history. So we have a little bit to work with here. But what I would like for you guys to do is pull out your pointers and underline things specifically, specific key phrases or words, being meticulous to leave out other things that aren't important, that are in fact important about this, this actual case. So things that are important about this history that we want to kind of pinpoint on. Good. So we have people kind of honing in on that multiple concussions. Good. No head trauma, exactly, or urinary incontinence. I agree with that. I think that that is, in fact, a pertinent negative. We would call that a pertinent negative. Continues to exhibit seizure-like activity. Agreed. Smell of popcorn. I agree with that as well. Denies any concurrent illness. Exactly. Still has seizure-like activity. Seemingly unconscious. Good. And he's 17. Yeah, I think you guys are kind of highlighting the good things. Something else that I would highlight here, I mean, some people may throw this into, like, you know, these cases to kind of throw you off, but I would highlight this. He was taking his final exam in algebra, because yes, you know, that this may be in fact a real seizure. It seems like it to me, but that's something we want to take into consideration, because it could be something that we call a pseudo seizure. You see it primarily more in psychiatric units and stuff, for different reasons. But that's something that we can kind of pinpoint to. Okay, what was the context behind where the seizure occurred? So somebody who's smart out there, let me clear all this. Somebody who's smart out there, tell me which lobe of the brain would be responsible for this. Do you guys know from your anatomy courses? So remember, we have the frontal, we have the occipital, we have temporal, and we have parietal lobes. So out of those lobes of the brain, which do you think perfect? So Sonal said temporal. Yeah, good, exactly. You guys are all kind of typing in temporal, exactly. So that's important to pinpoint, because okay, that tells us, you know, if the person had a issue with their you know, personality, maybe we say that that's frontal. They had issue with their eyesight, maybe we say it's something like the occipital. But we want to kind of pinpoint these different things of the history that may point us in the direction of what's going on. So we know that this is a young guy, a young gentleman of whom has played contact sports, has had multiple concussions, still has seizure-like activity, which is certainly an emergency. Do you guys know what that's called when someone exhibits seizure-like activity for longer than 5 minutes? It's okay if you guys don't. It's called status epilepticus. I don't even know if I spelled that right. I think I did. But that's what it is. And basically, it's when they exhibit seizure-like activity for longer than 5 minutes. It's certainly an emergency. Okay. All right. Let's keep going here. All right. So our questions that we want to kind of think of is, what questions do we want to ask about this patient? You know, either the patient, if the patient is actually conscious now, or to the mother, or to EMS. What questions do we want to know? What other things do we want to know about this history at this point? Yeah, good. Any family history of seizures? I agree. Certainly. How recent were the concussions? Absolutely, yeah. If this guy just got a concussion this morning at football practice, then that's something that we want to know. And we want to know probably how many concussions as well. Because if you guys probably know this if you played sports or have done sports medicine or anything, but there's kind of an advancement to back to sports in terms of concussions. And there gets to a point where if there's too many concussions, we question whether the person should be, the athlete should still be involved in sports at that point. Ever lost consciousness before? Absolutely, that's a great question. Any sleep issues? Sure. Good. What else? Issues with focusing? Yeah, good. Absolutely. Concentration is a big thing to ask about, especially now, because I can determine whether this patient's post-ictal still or if they've kind of come back from this seizure. Drug use? Absolutely. I think that that's very important. And something to remember, guys, is that, okay, yes, the patient isn't 21, but that doesn't mean that they're not getting their hands on this stuff. So it's better to always ask in a non-judgmental way, do you use any drugs or alcohol? Not frame it in ways that are like, I've even had like providers asking it in a way, it's like, you don't drink alcohol, do you? It's like, well, what are you going to say then? Of course you're going to be like, no. So it all kind of depends on the way that you ask it, and if it's in a non-judgmental way, then they're more receptive to you know, building that relationship with you and being honest. Personality changes, good, I agree with that. The stress before the exam, exactly, yeah, we definitely want to ask about stress and anxiety because that can precipitate different ailments. Any breathing problems? Sure. Before the seizure. Sexually active? Yeah, excellent. Especially if we have something that's causing, you know, meningitis that can cause seizures. So we would definitely want to ask about sexual activity, whether it's HIV, gonorrhea, chlamydia, different things like that. Good. You guys are on point here. One thing that I think it might be important to ask in general, someone said, has the losing consciousness ever happened in the past? I think it's important to ask, has this ever happened in general? Have you ever kind of exhibited this in the past? Has mom seen this? You know, what's the deal with this? Is this the first time this has happened kind of deal, or has this happened multiple times? All right, so now what differential diagnoses are we going to consider now? Yes, the patient it has a seizure, but what is causing this seizure at this point? So, you know, for instance, I'll give you an example so that we can build this up, but an example that we would say is, you know, seizure-like activity secondary to brain metastases or a brain tumor. So we could say that. Sodium and glucose levels. I agree with you. Very good, Sanal. I think that is 100% very important. We know that hyponatremia can cause seizures. It could cause a loss of consciousness. I think we mentioned it last week. We said when the sodium's low, it can cause altered mental status and seizures. So good. Temporal lobe epilepsy. I definitely agree with that. Epilepsy, good. We want to keep meningitis on our differential. I agree with that. We can say seizures secondary to electrolyte abnormalities. Anything else? What else do you guys want to consider? We could say brain tumor. Less common, but we want to keep it on our differential, especially if we're going to scan this person anyway. That's definitely something we want to consider. What else, guys? What other sort of neurodegenerative or cognitive or autoimmune things can we think about that may cause seizures? I hope no one was, I hope I didn't steal anybody's thunder there, but we want to consider something like multiple sclerosis too, that can cause kind of neurodegenerative things. We can ask if the patient has had any recent vaccinations or any recent exposures for something like Guillain-Barré. I'm going to put GB because I know I'm going to spell that wrong. What else, guys? Anything else you want to consider here in terms of seizures? We talked about electrolytes. We talked about temporal lobe epilepsy. So kind of a abnormal electrical activity. We're talking about infection here. We're talking about electrolytes here. We're talking about a tumor here. We're talking about autoimmune. And then we're talking about kind of environmental with Guillain-Barré, which is ascending paralysis, basically, that can cause seizure-like activity as well. All right, I think this is a good differential. Stroke, we can. In a younger person, it's a little bit a little bit more rare. We can put it on the differential, but there's gonna have to be something of which is going on that's causing that, because at 17 we haven't built up enough plaque and atherosclerosis to kind of block off some of those vessels. Yeah, we could have abnormalities in the vessels of the brain, maybe something like a AVM, an arteriovenous malformation. Certainly. Good. I think you guys are on the right track here. Yeah, we could consider something like a cardiac arrest. Like I was saying with stroke, probably less likely unless there's something kind of congenitally going on with this patient. So good. I think you guys have a great differential here. So let's see the next question. What test do you guys want to order based off of this differential? I kind of left it up so you guys can, still see it and kind of consider what you want to order. But let me know what you want to order, and we'll kind of go from there. Good, MRI. I think it's warranted for sure. We could probably go straight to an MRI as opposed to a CT. I agree. EEG, yeah. Good. CBC. Excellent. So what are you looking at for the CBC, Josh, specifically in this instance to rule in or rule out what you're thinking is going on? So CMP will look at the electrolytes. That's the complete metabolic panel. The other counterpart for the electrolytes is the basic metabolic panel. The difference between the two is that the complete metabolic panel has liver enzymes, whereas the basic metabolic panel does not. So we might consider that. There might be, something going on with the liver that can cause, problems systemically. So for CBC, we want to look at the white blood cell count in this instance, especially if we think there's an infection going on, an encephalitis, a meningitis kind of picture, so we can add that to our differential as well. I agree with the imaging. I think we can go to an MRI at this point. I think it's definitely warranted. CT scan can show us stuff, might not show us, a lot that's going on in the kind of white matter of the brain, but we can consider that. If it doesn't show us anything, we can definitely do a MRI, depending on our differential. Anybody else? So you guys said stroke and cardiac arrest. Does anybody want an EKG? Oh, good. Bridget and I were thinking alike, right? When right when I said it. So perfect. I agree with that. I think if there's something going on, we might want to rule out something going on cardiac that can cause something else going on in the body. So good. All right. We kind of went through that already in terms of what's important from the history. So we can kind of skip that question there, but let me clear all this junk out of here. All right. So let's keep going. So what parts of the physical exam do you really want to pinpoint on this young guy here? We know that he has had this kind of status epilepticus episode here. He's still kind of seizing when he shows up. What parts of the exam do you really want to pinpoint to kind of help your differential to kind of figure out what's going on? Motor function, good, I agree with that. So we'll do motor. Any specific tests that you want to do with motor? It's okay if you don't know. And we'll probably do a neuro exam. So we're going to test, remember our friends, the cranial nerves, when we talked about the pituitary gland, we talked about pituitary tumors. So we're going to test cranial nerves, probably 2, if the patient is responsive. 2 through 12. We don't really test cranial nerve 1 that's for olfaction. I've heard of physicians like carrying around like essential oils, or I think neurologists probably do this. I don't do it myself. Or they carry around like a thing of like coffee grounds, so that like they're like, oh, what does this smell like? And that tests cranial nerve 1. Personally, I don't do that. It would probably end up like all over my white coat or something. And that would be a mess. But so good, we can test strength, motor strength, exactly. We could test reflexes. This is all neurology stuff. We can test the patient's orientation. So like, where are they at? Kind of some of those questions that we asked our demented patient last week. Anything else you guys want to kind of pinpoint? If someone had a seizure, what do you really want to make sure they haven't done? We talked a little bit about urinary incontinence, but what about specifically with the head and neck? What are we looking at there? Yeah, making sure they didn't bite their tongue. Excellent. That's something we want to look at. We want to look at their mouth. Do you guys know, in terms of, some of you guys probably are paramedics or EMTs, but if someone is seizing, what do you do? So you can open their mouth. Sometimes we occasionally, not hands, you don't put your hands in their mouth, but put you know, either gauze or something, or something kind of hard, yeah, tongue depressor, to prevent them from clamping down on their tongue or their teeth. But there's one position that you kind of put the patient in. Yeah, roll them on their side. Do you know what side, Josh? Left lateral decubitus. So that's basically rolling them on their left side. So that's the position that you put them in, and kind of hold them there to prevent them from, you know, flipping, doing whatever, you know, and hurting themselves as a result. Why is it so important that the tongue isn't bit? Just because it's something that we can prevent, essentially, you know, and mainly because the force of the jaw is like very, very strong. So if they like bite off part of their tongue, that's like something of which likely cannot be repaired, and it's something that's very preventable. So we don't want the abrasions in the mouth and stuff, just because when they clamp down, they do it pretty hard. A lot of people, you could probably Google this now, but you see a lot of that damage that they have on their teeth, the people of whom have epilepsy. Sometimes they'll have a specific guard that they put in their mouth when they're seizing, or their you know, significant other or parents will put in their mouth. And you know, if you think about it, your tongue is very important for speech, so we don't want anything to kind of you know, go wrong with that. In terms of that, that's a great question. All right, so let's go on to our physical exam here, and like you guys kind of anticipated, this gentleman did bite his tongue, so that's what's kind of showing right here. But this patient has has a fever, is tachycardic. Blood pressure is a little bit high, but the patient is well groomed, not seizing currently, which is great. Minor abrasions on both of the patient's cheek and tongue with blood in the oropharynx. So there's no lymphadenopathy. The patient's tachycardic, but otherwise regular rate and rhythm. Clear to auscultation bilaterally. No masses in the abdomen, no tenderness to palpation. And then our neuro exam, we're not really able to perform it. So it doesn't really help us a lot, but we're unable to perform because of the mental status change. And that's what we call this post-ictal state. So sometimes you'll see that these patients, you know, they're very, very confused. It's like the lights are on, but nobody's home. And you're going to see that here in the next video that I'm about to show you. And it's just because of confusion. So as you can imagine, if you have all of this firing in the brain, firing of, you know, GABA, glutamate neurons in the brain, and all of a sudden that's shut off, it's going to take you a little bit of time to kind of come to that. And so you'll see that a lot of these patients kind of have a little more difficult recovery from these because of all of that activity in the brain. All right, let me clear this. Let me show you this next video.
Hi, baby. Okay? Okay. Keep this around. You don't need to pee on the bed. You're okay. You're okay. It's okay. Where's your bucket? This is really weird. It's okay. You need a bucket? No? You okay?
All right, so that's the kind of majority of the video there, but what I wanted you to see is kind of that post-ictal state where he, is obviously kind of, the lights are on, but nobody's home there. That's really what it kind of looks like. So that was kind of a good account of that. But we had another question here about the sodium levels, and basically in terms of sodium, what I want to show you is kind of this osmotic gradient here. And so we say this is kind of normal sodium. So the dots are sodium and the rest is water, okay? And basically what we see is if, this is normal, when we have hyponatremia, what we're seeing is more water, kind of that's what this is in basically. Sodium kind of is a solute that follows that solvent, which is water. And basically what we see is if there's more water here, basically what it's going to do is kind of cause that osmotic shift in the brain, causing more sodium to come out of the tissues to balance this, okay? So hyponatremia can certainly be a cause of seizures in the brain for that reason, okay? So all that stuff that you probably hated from chemistry, it kind of comes in handy a little bit here and there in the future, you'll see. So that's basically the problem with sodium and why it's so important. All right, so let me clear that out and we'll keep going here, talk a little bit more. So here is the labs. So you'll see, here's the little fish diagram over here, so you can kind of follow. But basically here's the sodium. It's a little bit low, but we'll see that that's not low enough to cause kind of this seizure-like activity. So yes, it's low. Maybe it's low because of the seizure, but we think that, there's not maybe a threshold for it, but I would say definitely lower than that, probably in the 120s, likely to cause seizure-like activity. This is just barely low. Otherwise, potassium, chloride, CO2, everything else is good. Somebody wanted a glucose, that was okay. So good guess on that one to make sure the glucose is low. That can definitely cause it as well. We see our friend prolactin here is high. That's usually an indicator that a true seizure has happened. So sometimes you'll see it afterwards elevated, and we'll talk about that in the next slide as well. CBC is normal, even though the patient is febrile, could be from all that muscular activity, that contraction in the muscles, causing that to be elevated. H&H is normal, so that's a hemoglobin. Here's the hematocrit, and then platelet count is normal. Okay, so what we're really seeing here is a high prolactin and a slightly low sodium, but not enough here to cause problems, I think. So, all right, so here is a slide where we're going to kind of talk about basically why the prolactin's elevated. So basically what we're going to kind of pinpoint here is the pituitary gland. If you guys remember from our cranial nerves lecture where we talked about the pituitary gland, remember that our friend, the pituitary, from the anterior lobe of the pituitary, so it kind of is that stalk that sits on the sella turcica. Here's the sella turcica. It literally means in Latin, Turkish saddle. Basically, what we're seeing here is that because of this electrical activity that's going on in the brain, also I outlined the wrong thing. Hypothalamus is up here, sella turcica is down here, so strike that. But basically what we're seeing here is that because there's so much electrical activity going on, we see, or it's hypothesized that the reason why the prolactin goes up is because of the electrical activity affecting the pituitary gland. Okay, so that kind of makes sense. So we see all this crazy electrical activity in the temporal lobe, which is what we're kind of pinpointing here is the temporal lobe, that causes the release of prolactin from the anterior pituitary, because we know posterior pituitary is primarily oxytocin and ADH. So that's kind of a little bit about why the elevated prolactin. You know, that's not a question or anything on your quiz or anything like that, but I like to kind of know the why, because then you can understand the bigger picture. Okay, so the main thing I want you to remember here is kind of make that connection back to you know, our cranial nerves lecture, where we talked about, you know, here's the brainstem, we have the cerebellum kind of sitting behind. Then we have the actual cerebrum, where we see the frontal lobe, occipital lobe back here, part of the temporal lobe, and then parietal lobe. Okay, so there's that. So a little bit of neuroanatomy there. We see the ventricles here in that turquoise color. The hypothalamus sits above the pituitary gland, which kind of sends that signal to the pituitary. And we have our friend the Turkish saddle down here. And that's about it. We talked about the optic nerve a little bit when we talked about the visual fields, but that's about it for this. So let's keep going here. We'll talk more about this case. All right, so here is our MRI of the brain here. So where is this signal happening at? You guys tell me that. What part of the brain is that? Good. So yes, that's in the temporal lobe. So we'll see a little bit here, down here, we can see part of the cerebellum. We see that this is exactly, you guys are right, the temporal lobe. You see top of the parietal there, depending on the kind of slice that is happening here. But this is the temporal lobe. We see kind of a bright signal in the temporal lobe, maybe suggesting temporal lobe epilepsy. But let's keep going here. And we're going to talk about how to read an EEG first. I didn't want to just throw you guys an EEG and say, well, what's going on here? Because this is pretty difficult and really kind of above the level of even medical school, but I think it's kind of cool to know. So I'm going to teach you guys this here. So basically, you put all these leads on a patient's head, and you guys may have seen this or seen it on, you know, I don't know, movies or whatever, but basically all these leads are put on the head to kind of monitor the electrical activity of the brain. And we could do one of two things. We could do a continuous EEG, where we kind of measure over a long period of time. That's what we kind of want to do if we're going to try to suss out electrical activity, why somebody's not waking up from anesthesia, if, you know, they have epilepsy, as opposed to like a spot EEG, where we're just doing it at one point in time. Okay, so those are the two different kind of that we can do here. And we'll see here on this EKG or EEG, we see, you know, different electrical activity corresponding to different areas of the brain. So F is for frontal. We see a frontal polar there. We see central. So that's right here, that's C. Excuse me. Then we have parietal, we have auricular, that's they put one on the ear. We have occipital, we have temporal. Okay, so all of these leads are kind of corresponding to a specific mapped area on the brain. So that way, if we see, you know, different spikes like this, we can kind of tell where that's coming from. And what we'll see sometimes is if the patient's active doing something, we might see spikes there as well. If you're asking them to do something, or if you're not and they're just having them rest and you see a spike there, we might say, okay, there's, you know, abnormal electrical activity coming from this area. They may have epilepsy, or they may have seizure-like activity in this spot. So that can kind of lead us towards our diagnosis. All right. So your guys' task now, and I know the image blown up is not perfect here, but I want you to kind of tell me which area or areas do you think that the patient is having a problem at, based off of, reading the EEG. Where is this patient having an issue? Good. So somebody said temporal. I agree. And if you guys are like, well, I don't know how we even got there, let's go through it together. So basically what we see is, yes, there's a white line here, but what we're looking for is those spikes in electrical activity. So we kind of see a couple here where, it's an undulating baseline like this, and then we see a big spike like that. Okay. And that's what we're looking at here, and then here. And we do see some kind of in this like T3 area as well. So there's one here, but what we're looking at is this T3 to T5 telling us, okay, this is in the temporal lobe area. And that matches, remember back to the case when he said he smelled popcorn before the seizure. That makes sense because we know that the temporal lobe kind of controls function of our olfactory sense. The way I always remembered it when I was in school is that your ears your ears basically kind of that area that's in the area of the ears, I always remember is paradoxically for olfactory sense. So that's kind of a little clue there. We know that the temporal lobe kind of controls hearing as well. So that's a little bit of a clue in both of those regards, but there's a kind of quick introduction to the EEG. Since the EEGs are usually taken after the seizure occurs, would we be able to see these spikes? That's a great question. And that's one of the reasons why in the hospital, what we'll do is do a continuous EEG. Because sometimes, you'll be sitting there, like, oh, this EEG is normal, nothing's going on. So it's not telling us really anything that's going on. So we might do a continuous EEG to kind of suss out to see, if this is really occurring, aside from when the patient's being medicated or when the patient's normal in that instance. All right, so we might do it over a period of time. So that's a good question. All right. So, and this was kind of the read for this kind of left temporal spikes, sharp waves with phase reversal. So good, you guys got the temporal lobe correctly. All right, so here's our, we're kind of to our diagnosis, our assessment and plan here. But as you guys kind of indicated, we're calling this temporal lobe epilepsy. I put a question mark there because basically we saw it in this one EEG. Do we know it's epilepsy yet? Epilepsy by definition is kind of multiple seizures. If you have one seizure, that doesn't make you an epileptic, because you can have one seizure for a multitude of reasons. You can have a febrile seizure, you can have it because of alcohol, you can have it because of withdrawal of alcohol, you can have it because of a brain tumor. That doesn't make you necessarily an epileptic. Okay, those are two different things that I think gets a little bit confused sometimes. But what we know for sure is that this patient probably was in status epilepticus, and there is a very meticulous thing that we do to treat status epilepticus, and that's usually treating with benzodiazepines, like lorazepam. We give it IV, and that's in the first 30 minutes. So we have kind of this algorithm. And if it hasn't worked in 30 to 120, we usually treat with like phenobarbital or phenytoin, usually phenytoin, of which is an anti-epileptic drug. And then usually if this goes on for greater than 120, usually we do things that are often general anesthetics, so things like propofol, midazolam, or barbiturates that will kind of depress the central nervous system activity of this patient, because we know that when this goes on for a long period of time, this is very detrimental. Obviously, there's lots of electrical activity going on in the brain. That's an issue. So we want to make sure that that's kind of stopped after a while. This image here kind of shows you, what we're going to do basically is treat with anti-epileptic drugs, and then we're going to kind of monitor, do drug monitoring. So we draw the blood and see the levels to make sure that this patient is in therapeutic range. So that's kind of the headache with these drugs, is there's a therapeutic range for a lot of these drugs. So there's definitely a lot of time and effort invested into this, and all these drugs, a lot of which are effective, act in different ways. So we see, different drugs here like phenytoin work on these voltage gated sodium channels in the synapse of the neuron. Same thing like lamotrigine, carbamazepine, those are some that you may have heard of. Levetiracetam kind of works on some of these vesicles, specifically here on the SV2A receptor there. And then we have different things that work on like calcium channels. Ethosuximide is one of them. Ethosuximide is a drug of which is almost exclusively used for absence seizures in children. You'll hear about absence seizures in a few minutes when we talk about the different types. But basically, these are the kids that are sitting in class and everybody thinks they have ADD, but basically what's happening is they're normal, and then all of a sudden they have a seizure and they're just sitting there blank staring, and then all of a sudden the teacher's in their face saying, "Tommy, why aren't you paying attention?" But it's because this kid is having a seizure and not necessarily, not paying attention. So basically, bits and parts of this kid's world are kind of broken up because they lose consciousness in that time. Absence seizures, where basically they're absent, is treated with ethosuximide. Okay, so that's a little bit of an introduction to all these drugs. It's fairly complex. So we know that a lot of it kind of works on GABA, glutamate. It works on the neuron synapse in general. All right, so let's talk a little bit of the pathology now that we kind of got through, seizures in general, epilepsy in general, how we treat these things in general. Basically, as we kind of talked about, this is abnormal electrical activity. We can see loss of consciousness, we can see sensory disturbance, and we can see convulsions. We saw sensory disturbance in this patient in terms of them having that abnormal smell. How do we diagnose this? We can use things like CT. We use an MRI here, so that should certainly be listed as well. That's horrible writing. MRI. We can use things like the EEG, the prolactin, not to kind of diagnose it, but to kind of delineate between pseudo seizures and true seizures. We can use labs to discern if there's a secondary cause. So hyponatremia or infection, remember, can be causes. We can use LPs as well if there is a secondary cause. So if we're suspecting that this patient has meningitis or encephalitis, we might want to do an LP to kind of delineate that. Or multiple sclerosis, we might do an LP as well. But we're going to kind of draw your attention now to this little diagram over here and kind of talk about how we delineate these seizures and how we call them. Because what you guys are probably used to is this kind of grand mal tonic-clonic seizure. And when you think seizure, you probably think of that, where someone, kind of falls out of their chair and then kind of tenses up and then kind of shakes. That's probably what you think of. But there's so many different types of seizures, and kind of delineating what the type is important, because as we've kind of talked about through this lecture series, the treatment for it is correspondingly different. Okay, so we'll want to delineate it so we can get the right treatment that's going to kind of keep their seizure, their basically raise their threshold so that that electrical activity doesn't happen. All right, so basically seizures, we delineate them by two different things. Partial or focal seizures, where it's kind of in a part of the brain as it's kind of shown there, or generalized seizures where they kind of happen throughout the brain. In terms of partial seizures, we delineate them by loss of consciousness or not. If there is a loss of consciousness, we call that a complex seizure, and if there's not, we call that a simple seizure. But something that's important to remember here is just because it's partial doesn't mean that it can't progress to become generalized, and that's what this is showing here. So it can become a secondary generalized seizure. And then when we jump over to the generalized side, we know that there's multiple different types of generalized seizures. Remember our kid over here, that's basically what an absence seizure is. It's treated with ethosuximide, where they kind of get that that blank stare, but afterwards they're back and they're fine. It's like somebody turned off the lights and that's it. They kind of stare. They're having that electrical activity because it's a generalized seizure, but they don't have that postictal confusion where they're very confused, like our gentleman that we saw earlier. Okay, another word for this is a petit mal seizure. Another thing is atonic. So we kind of talked about absence. So atonic is kind of another word for that is a drop attack. Sometimes we see that in children where they're just normal and they kind of drop, and they get atonic, meaning they lose tone from their body. Okay, so it's you know, a little bit opposite of the tonic-clonic seizure where they get real tense and tight. The kind of counterpart to that is the tonic, where they just get kind of tight. They don't get that shaking, but they stiffen up. And then we have myoclonic, which is kind of repetitive jerks. And I know that that is like kind of hard to delineate from tonic-clonic, but it is a little bit different. It's just quick and repetitive jerks, maybe in one area of the body, depending on where the seizure-like activity is. And then the one that you all are probably familiar with is this tonic-clonic, where they have that alternating stiffening and kind of movement where they're shaking. Okay, so this is kind of a big picture of all of these different types of seizures, kind of bringing your attention to the fact that there is a lot of different types of seizures, and delineating what the seizure type is can be important. All right, so here's kind of our continuation. What we're talking about here is the neuron. So we're looking at these synapses, we're looking at the electrical activity, because we're looking at things like sodium, we're looking at things like GABA, we're looking at things like glutamate in these neurons being released. And when we talk about the electrical activity, we're talking about synapses between neurons in the neurotransmitter system. So you guys may be familiar with this so far. So here's a sending neuron, here's a receiving neuron, and basically these neurotransmitters are packaged up in these vesicles. You know, there is a sodium signal and a calcium signal that come in. Calcium causes the release of these vesicles, and it is released into the synapse, and it binds to this receiving neurons, a secondary neurons receptor, and then you get a cellular response. So what we see and what that looks like in terms of electrical activity is this. So what we're looking at is these things called action potentials, and I know that you guys might be familiar with this. If that's okay, if not. And that's what I'm talking about here when I say thresholds. That's really what I'm kind of getting at, because when we treat someone with an anti-epileptic, basically what we're doing is we're taking this threshold and we're moving it upwards. Okay, we're not eliminating or curing seizures, but we're making this threshold higher so that more electrical activity is required in order for them to have that seizure. Okay, so I hope that makes a little more sense. But basically what we're looking at is there's a stimulus, so those vesicles are released. You know, we have all these secondary neurotransmitters. Here's glutamate here, and we have this presynaptic neuron, it's releasing it. And what we're seeing in this image over here to the right is that glutamate binds, and calcium is the second messenger here, basically. So that's kind of another image of that. But what we're seeing in terms of the action potential is sodium is part of this first upward phase of the action potential. Okay, so that's what's happening here. Sodium's coming into the neuron at that point, and we're getting an action potential in that regard. All right, and then on this downward phase, phase here, we get potassium. So remember these two ions, these are always important for the action potential. If you guys don't remember your action potential physiology, that will be a question on your quiz later, so remember that. So when we have that upward phase of the action potential, that's primarily due to sodium. And then we get potassium kind of coming in to go down to this refractory period. And this is when, sodium channels are opening. This is when sodium channels are closing about this time. And this is when potassium channels are opening. Okay, and then we get down to this refractory period where we go below that, obviously, that threshold and that stimulus, and we get back to that resting phase. So this is truly what the action potential is kind of looking like. And what we're talking about here. So remember our sodium that we saw in the action potential. Basically, that's what we're seeing here. So when we get that glutamate or whatever that neurotransmitter binds, sodium's coming in and starting to ramp up that action potential. So we're going like this. We see, obviously, this doesn't show us our potassium here, but it's going to go up. And then at a certain point, those sodium channels are going to close. Our potassium is going to open, and then we're going to go down like this. And then we know that also calcium and magnesium are involved here in this this image. But remember, our sodium is going to be important, and so is our potassium. Calcium is always important for muscle contraction as well. If you remember that kind of actin myosin bridging and stuff, calcium is important for that as well. All right, let's keep going here. So when we talk about pathology of seizures, when we talk about the etiology and the risk factors, often seizures, we don't know why it happens. It just happens. But in other times for children, we can have congenital malformations. So that's, things like the arterial venous malformation. You guys put that on your differential. Things like head trauma, inherited syndromes, and then adults. There's tons of things that can cause it. So things like stroke, alcohol withdrawal, we call that status epilepticus, secondary to DTs, which is important to avoid in people whom are withdrawing from alcohol. Things like Alzheimer's disease, we have other electrolyte disturbances, things like fever, endocrine, we talked about all those ones. Medications, of course, renal failure, lots of different causes of it. How do we treat this? Anticonvulsive therapies, so we kind of talked about that. Another cause is obviously brain tumors. So I put this picture, CT scan of, multiple metastases. If we remember back to last week's presentation, most common cause of brain tumors is metastases. Primary brain cancers are not that common. So if you see a brain tumor, it's likely a metastasis. Okay. And that's it. So I finished, I thought there was definitely more slides, but it looks like I'm right on time. Let me launch this poll one more time here, see your guys's answers, and I'll stick around for a few minutes afterwards to answer any questions you guys have. I know that this was a lot and kind of, it can be complex, whether it's the physiology or the etiology of all these different things. So if you guys have questions, please let me know. I'll be happy to stick around for a little while and answer anything about seizures or anything about medical school or anything that you guys like. So seizures usually last like seconds, and that's why it's a big problem. And I know when I say, seizure-like activity that lasts longer than 5 minutes, you're probably like, well, that's not a long time. But if you think about all that electrical activity going on in the brain, that is a very long time. So it's usually, very, very short, like 10 to 15 seconds, 30 at the most. Not usually that long of a time, but it certainly depends on its etiology as well.